Diagnosis and treatment of hypertension depends on accurate measurement of oscillatory blood pressure. The lowering of target blood pressure for patients with diabetes or renal disease has made detection of small differences more important. True blood pressure is defined as the average level over a prolonged duration. Systolic and diastolic blood pressures are preferred for use in hypertension classification, rather than arterial or pulse pressure. A classification of hypertension and prehypertension from the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure is normal 119 or lower, 79 or lower. Prehypertension 120 to 139, 80 to 89. Stage 1 hypertension 140 to 159, 90 to 99. Stage 2 hypertension 160 or higher, 100 or higher. Prehypertension has increasing health risks and can progress to hypertension. The position of the patient can have a sizable impact on blood pressure measurements. For the most accurate measurement, the AHA recommends that the patient be relaxed and seated with legs uncrossed and back and arms supported. If possible, the patient should be seated 5 minutes before the reading. All clothing covering the cuff location should be removed. The middle of the cuff on the upper arm should be level with the right atrium, at the midpoint of the sternum. If the upper arm is below the level of the right atrium, the readings will be too high. If the upper arm is above the heart level, the readings will be too low. In the supine position, the arm should be supported on a pillow to raise it above the level of the heart, which is situated about halfway between the bed and the sternum. In women who are pregnant, the left lateral recumbency position can be used with measurement on the left arm. Patient recommended cuff size. Adults by arm circumference. 20 to 26 centimeters, 12 by 22 centimeters, small adult. 27 to 34 centimeters, 16 by 30 centimeters, adult. 35 by 44 centimeters, 16 by 36 centimeters, large adult. 45 to 52 centimeters, 16 by 42 centimeters, adult thigh. In older patients, blood pressure should be measured routinely in the standing and seated positions to screen for postural hypotension. The most common error in blood pressure measurement is the use of inappropriate cuff size. For correct cuff placement, the midline of the cuff bladder should be positioned over the arterial pulsation of the patient's upper arm, following palpation of the brachial artery in the antecubital fossa. There should be a 2 to 3 centimeter space for the stethoscope between the lower end of the cuff and the antecubital fossa, unless this would require an undersized cuff. In patients with an arm circumference greater than 50 centimeters, the cuff should be wrapped around the forearm, supported at heart level, and the radial pulse felt at the wrist. The AHA recommends that the cuff be inflated to at least 30 millimeters Hg above the point at which the radial pulse disappears. The cuff should then be deflated at the rate of 2 to 3 millimeters Hg per second, or per pulse when the heart rate is slow. Deflation rates greater than 22 millimeters Hg per second can cause the systolic pressure to appear lower and the diastolic pressure to appear higher. The AHA recommends that at least 2 readings be taken, with a 1-minute interval between them, and the average of the measurements recorded. Early morning and evening readings are especially helpful. The upper limit suggested by the American Society of Hypertension is 135 over 85 millimeters Hg.